So last time we talked about how to read normal MRI of the brain. And now I'm going to talk about some examples of abnormal MRI of the brain. And it's such a big topic that we will not be able to cover everything. But I will give you some examples of each disease so that you will have, overall idea of how different pathology looks in MRI, so that you can, build up your knowledge on that. So I will start with brain tumors, which is one of the common pathology that we see in MRI. And this is a pituitary adenoma, sagittal view T1, plain on left side and enhanced on right side. So you can see that there's a round oval cellular lesion which has extended above the cella, and so the pituitary tumor will look like this. Another pituitary adenoma case where you can see a cellular lesion with supracellular extension. The optic chiasma is riding over in the enhanced image. The optic chiasma is riding over the cella, and then you can see the vascular branches there. And on an axial image, this will look like this. Another case of pituitary adenoma, different degree of extension. This tumor has extended vertically upward, but then there is no lateral extension into the cavernous sinus. And so these are very easy cases for transpenital surgery. And here you can see that there is some invasion of the cavernous sinus on left side and minimum on right side. But actually in these cases, these tumors have not invaded into the cavernous sinus itself, but the medial wall of the cavernous sinus is just pushed out. And those two, flow voids are the carotid artery. And then you can see that there's a pouching of the tumor towards the right optic nerve, chiasma and optic nerve. So this patient most probably came with a right-sided vision loss. And here is an invasive type of pituitary adenoma where you can see that there is no vertical extension of the tumor, but this tumor has extended into the cavernous sinus, and the carotid artery is totally engulfed within the tumor itself. So it's a true cavernous sinus invasion of pituitary adenoma. Sometimes you see in invasive type of adenoma and Cushing syndrome and so on and so forth. Sometimes the pituitary tumor will be so small that you will not be able to see it. So you may have to do delayed images like this, where the sagittal image shows that there is, the rest of the pituitary gland, the normal pituitary gland is enhanced, whereas the pituitary tumor, which is micro, this is in this case a microprolactinoma. Sometimes, ACTS producing Cushing's pituitary also looks like this, but most of the time it's a prolactinoma. So here there is actually the same case here. You can see that there are some signs which will suggest that there is tumor here. One is that the pituitary stalk has been deviated to the right side, and then you can see that the floor of the cella is a little bit inclined toward this side, and the dome of the the diaphragm cellae is pushed up. So you suspect something here, but when you do enhanced scan, then you can see it like this. So pituitary tumor enhanced a little bit late, so they look like this, and at the end, they become bright. So sometime if the tumor is very, very small, then you may have to do a dynamic MRI, like in this microprolactinoma. So you give a gadolinium enhanced contrast and then serially take the picture. And then you can see that the normal pituitary has enhanced surrounding, a tumor there in the center of the pituitary. And a little bit of pushing of the stalk is on the other side. So, you keep on taking few images on the same slice, maybe two slices you fix, and then you continuously take at that spot, and then you can dynamically see that the pituitary adenoma looks do not take up contrast early. Another case that you see in cellular region is craniopharyngioma. There are different types of craniopharyngioma that you can see. Here it is a solid type of craniopharyngioma, most likely a child, which has got a cellular and supracellular ventricular extension, and it's a mixed intensity lesion with the contrast, pretty bright take up of the contrast, and you can see that there's a little bit of hydrocephalus also. Another case of more of a cystic lesion here, where you can see that there's a hydrocephalus, asymmetrical hydrocephalus. The left side ventricle is a little bit more larger. The temporal horn on the left side is larger than the right, but both are prominent. So this patient, in this patient, the Monroe is being compressed by the lesion itself and giving rise to asymmetric triventricular hydrocephalus. Another case of craniopharyngioma, it's a mixed type where there is a cystic as well as solid component, and the cystic part is not being enhanced, while the solid part is being enhanced. So it's a mixed type of craniopharyngioma. And in the previous slide also, you can see that the sella is totally separate. So it's a supracellular, typically a supracellular lesion. And here also you can see that the sella is spared, the pituitary gland is spared, and the tumor is actually above this lesion. This is a pontine glioma. Here you can see that the pons is infiltrated with on T1 it's an iso to hyper, and T2 is a hyper, and you can see that the basilar artery is actually invaded into the pontine glioma, and you don't see that there is any exophytated area. So it's within the pons, and there is no point from where you can actually go in, or there's no point where the tumor is coming out. So these are called diffuse intrinsic pontine glioma, and so these are very, very difficult case to operate on. And another case of diffuse pontine glioma, post contrast, there is no enhancement at all. And then you can see that the pons is enlarged, so it's being pressed on the clivus. So sometimes this is a better case, pontine glioma, but then this is an exophytic pontine glioma, where you can see that the tumor has come out of space there, and then it's exophytated. And in such cases, then you can just follow that track and go into the tumor and go into the pons and remove it. So intrinsic is a very difficult tumor. Exophytic pontine glioma is a little bit better pathology. So coming to high-grade glioma, I will straight away go into multicentric high-grade glioma, which if you see multiple lesions in the same patient, then like this and this, then this is a very, very high-grade glioma you can suspect, or a metastasis. And so, most of the time they are in one ventricle, but that can be on the other ventricle as well. And in some high-grade glioma, you can see that the main tumor is there, but then there is a satellite of lesion a little bit away from the main tumor like this. So satellite lesion like this, which also again denotes that these tumors are very, very high-grade. This is a butterfly, high-grade glioma, which is, through the corpus callosum on the posterior part on the splenium. The glioma has spread from one hemisphere into the other hemisphere. It looks typically like a butterfly. So this is a very, very high-grade type of glioma. And since it's, occupying both of the hemisphere, these are almost untreatable, or you can just do a small biopsy or some kind of decompression, but then these will come back again. On the other hand, low-grade glioma do not enhance that much. So, the lower the grading, then the enhancement becomes less and less. Like here, the gray-white matter differentiation is gone here. And then you can see that there's some edema around it, and there's a mass effect. And even after contrast enhancement, there is minimal or no enhancement. And you can see that the ventricle is being pushed to pushed a little bit inferiorly in this case. Now, another case of low-grade glioma at the base of the skull, which is, infiltrating into the temporal lobe and partly into the insula, and then through the, to the thalamus and also to the opposite side of the ventricle. So, opposite side of the hemisphere through the, inferior aspect of the falx. So, it is a low-grade glioma. Maybe it is a converting into a high-grade glioma because there's a lot of mass effect that you can see here. Some of the examples of intraventricular tumor, like this case, is a central neurocytoma, where you can see there's a cystic component and a moderately enhancing lesion within the ventricle itself. And it's a centrally located, and central neurocytoma are, very, very good cases for surgery, and then they do pretty well after complete excision. Another is a subepidermal giant cell astrocytoma of Sega. This typically is seen with enhancement pretty bright and may cause some, asymmetrical ventricular dilatation, because this will compress on the foramen of Monro. And then it is subependymally starting from generally from the caudate head or that region, and most of the time it obstructs the foramen of Monro and give rise to hydrocephalus. And these are also very good candidates for total excision and then long-term good survival. Now, coming back to extraaxial tumor, this is a vestibular schwannoma post-contrast. This is another case where it's a heterogeneous. This is T2, this is post-contrast T1, pretty heterogeneous, and it's not homogeneous as such. And then you can see that there is a, tumor that is extending into the internal auditory meatus, looking like a ice cream cone. So this is the extension of the tumor into the internal auditory meatus. And in this case, you can also see that there is a small cleft of CSF around the tumor, which is a very good sign that you have a cleavage there of CSF. So, while pulling out the tumor, you don't pull out the brain itself. But if this CSF cleft is gone and there's an edema around it, then that is a bad case. So this means that it has invaded into the arachnoid and to the pia, and then the chemical structure, chemical part of the tumor has gone into the brain, causing the edema. And then that causes adhesion, and these are more difficult cases. But this looks like an easy case. And fourth ventricle is well compressed. You can see that the cerebral peduncle is compressed, the pons is compressed, but still there's a very nice cleft around it. This is now, if you look at this, then there's a difference because there's no coning, although the site is almost the same. This is the sigmoid sinus, and then there's a big attachment here. It's not oval in shape. So these are petrous meningioma, and meningioma most of the time looks more heterogeneous, and we don't see that much of cleft in this case, but then there is no edema as such around it. So still I think there is no invasion into the brain itself. So this is, tentorial meningioma or petrous meningioma. Now, another case of clival meningioma, where you can see that the tumor is arising from the clivus itself, attached to the clivus, a very difficult case, because to approach this tumor from either side, it's very, very difficult because it's right in the center, not asymmetric, so you don't know from which side to go. And it's compressing on the pons, and there is already some hydrocephalus there. Temporal lobes are enlarged, and the ventricles are also enlarged. Now, this is a typical case of a convexity large meningioma, which is, invading through the falx into the both of the hemisphere. And probably the origin is somewhere around here in the frontal bone, because you can see that the bone has, been exophytated, and it's invading into the tumor. So these are, this is the main attachment from where the main the vasculature goes into the tumor itself. And you can see that there is some edema around the tumor. So this has invaded the arachnoid, the pia, and then the chemicals of the tumor has gone into the brain, leading to edema. So this, you have to be pretty careful when you dissect out the tumor from this area. And this probably is a very, it's a low intensity area or calcification in the center of the tumor, and then probably a lot of vasculature coming from the fox itself. This is a case of a diaphragm cell meningioma, where it looks like, again, like a pituitary tumor or craniopharyngioma. But then if you look at, there are some hallmarks like there is a dural tail, there's a tail-like thing which is coming. So this is also extensive of the tumor. If you operate here, then you see that there's more vessels and some tumors there. So you have to chase, all the way up to the end of the dural tail. And then you can see this is also called a bulle. The spinous sinus has, a little bit enlarged into the tumor. So this is a very, very hallmark of a meningioma, So this is a tuberculum cellae or diaphragm cellae meningioma. Again, very homogeneously enhancing tumor in the foramen magnum area. So this is a foramen magnum meningioma. So a differential diagnosis could be hypoglossal or hypoglossal neurinoma, but then in hypoglossal neurinoma, the tumor extend into the hypoglossal nerve. So you can see some tumor into the hypoglossal, the direction of hypoglossal nerve as well. And those tumors are not that homogeneous like in this case. And this is ethmoidal meningioma. Probably the patient do not have smelling power because both of the ethmoid, the olfactory area is gone, and this has actually invaded the anterior skull base and has extended a little bit into the orbit and ethmoidal air cells. And there's a lot of edema, which denotes that it has invaded into the brain itself. And the attachment is very, very large. So, there's a lot of feeding coming from the skull base. So, you need to detach everything before you remove these tumors. So, attachment is big, there's edema, and then, the whole both side of the brain is involved. These are difficult cases again. Now, coming back to not very common pathology, but sometimes you see in this image, you see that the eye is proptosed, coming out of the socket, and there is a glioma, which is, there's a tumor which is involving the optic nerve to the optic canal into the intracranial structure as well, or almost at the foramen, So this is an optic nerve glioma. Probably the patient is already blind on that side. And but then most of the time, optic nerve glioma are pretty benign tumors. So once you remove it, they do pretty well. This is a case of, acoustic neurinoma, but on both sides. One is bigger than the other, and the brainstem is squeezed between the two tumors. And then if you notice, there is another tumor here, which is a meningioma. So bilateral acoustic neurinoma with only then you can say that it is neurofibromatosis type 2, but then with meningioma, also you are very, very strongly say that this patient have multiple tumors and meningioma, neurofibroma. If you screen the spine, then you will see many tumors in the spine as well. And so this is a pineal gland tumor, which is quite brightly enhancing, and in the posterior aspect of the third ventricle. And there's also a hydrocephalus on both sides, as you can see. And so another case of pineal gland tumor, but then this is quite big. So there is a, you can get a little bit confused with whether this is a tectal plate glioma or a pineal gland tumor, And again, the third ventricle is ballooned up. The Monroe has been rising up here, and there is hydrocephalus because of the compression and obstruction at the aqueduct. Sometimes you see lesions like this when you do a routine MRI head. or with headache. Patient may come to you with headache. There is a cyst at the foramen of Monroe area attached with the fornix, and different size, and depending on, so this patient has got a little bit of hydrocephalus, because you can see that the CSF is, there's a transependymal seepage of CSF, which denotes that intermittently there is a rise in ICP in this patient, and maybe the cause of hydrocephalus. Sometime the colloid cysts, these are colloid cysts, and these colloid cysts may be larger, and but then they may not be symptomatic. Another example of colloid cyst with, colloid cysts can have different mix, can look different in T1, T2 flare and enhancement, depending on the extent of the fat into it and the extent of the vascularity. Just a note of brain metastasis. Whenever you see a multiple lesions like this, then this can be some kind of metastasis. So you have to look for a primary in the body, and the chest and abdomen, and or it can be a solitary. Still, this can be a metastasis. And most of the time, metastasis means the tumor is metastasizing from lungs or liver, or prostate, or different part of the body, which is with the tissue is foreign to the brain. So there is most of the time many edema around it, because it's trying to because of the immunity reaction to the foreign tissue that has come there. Some cranial infection that I want to show you, this is a case of tuberculosis, where you can see in the thalamus area there is a, in T1 iso, T2 is low, and then with edema around it, and you can actually see the, internal capsule, level of the internal capsule also. And so this is a herpes simplex encephalitis of temporal lobe. And the herpes simplex generally, attacks the temporal lobe itself, and then it will look like this. Brain abscess can look differently, like this one, which shows that there's a clear-cut wall and a cystic component and lot of edema, because brain abscesses always have a lot of edema. But sometimes, if the wall is very thick and there is no immunity reaction, no connection between the cyst and the brain, then there may not be edema, but most of the time they will have a lot of edema and then symptomatic. Or they can be multiple septated cysts like this. And their wall is quite clear, and it looks like it's a tense, it's a tense from inside trying to burst out kind of look. And some brain abscess can be like this at the surface of the brain, and then a lot of edema. But then if you notice, there's a subdural part of the abscess which is extending into the frontal lobe. Same image here. And there's another case of subdural brain abscess, which is like this. There is some examples of vascular lesions. So you can do a angiography, MR angiography, even without a contrast, and get a very nice image like this. I will not go into detail of angiography here. I will, talk about it in another video. And before you go and talk, you may have to go into what normal brain looks like, where I have talked about MRI of normal brain. In this image, you see that the one of the middle cerebral artery is completely occluded on one side, so you can suspect that the patient will have a lot of middle cerebral artery infarction. And this patient have multiple stenosis, but then still the middle cerebral artery is being visible. Means that the patient may come with you with the stroke or TIA or RIND, many times small ischemic attacks. Again, it can be a complete IC occlusion, and then you only see that the IC on one side and nothing on left side. These are very, very bad cases if they come with stroke. But some, if actually the IC, if it's slowly occluded, then they may tolerate even IC occlusion. So MCA infarction will look like this, and here you can see that the part of the MCA is occluded, not the whole thing. Again, the MCA occlusion, the ACA territory is spared. The thalamus feeding places is spared. The posterior cerebral part is, so this is ACA, it's spared. So it's a typical M1 segment infarction. And if you have an anterior cerebral artery infarction, then it will look like this, the anterior cerebral territory. And if you go above, then it will come back and back, and all of the leg area will be, infarcted. So they will have deep leg weakness. PCA territory infarction, selective PCA territory infarction, where many times you see when there is a brain herniation, you see something like this, but this is a case where there's an embolism of the PCA, so the rest of the brain looks normal. But if you have some, very high pressure, intracranial pressure, and then that leads to herniation, then the PCA gets stretched, and then also you can have a PCA infarction like this. And if you see that you have a pathology with an infarction, then these are very, very bad cases. You can see aneurysm like this from MR angiography, but then I will talk about this in another slide. But sometime these can look like a foreign body or tumor or something in the brain, but then you can see that there is a flow artifacts there, and then there's a lot of a void area, and then you can see that the wall is very, very clean cut, very, very sharp, clean cut wall. So the aneurysm, giant aneurysm, will look like this. Another case of a giant aneurysm with MR contrast, where a lot of contrast is taken up. And if you see something like this, this is on the posterior fossa on right side, you can see that there are a lot of flow voids here, spreading into the whole of the right side of the hemisphere. And then there are loops, and then there's a big, most likely a venous drainage. And so this is a AVM, arteriovenous malformation, diffuse arteriovenous malformation. And if you do a contrast, it will look like this. And if you do a MR angiography, the AVM will look like this. Another AVM case will flow void, and then if you do a MR angiography, it will look like this. And you can also look at, looking at the speed of the flow, you can look at the venous sinus and look at the symmetry of the venous sinus. Here you can see that the transverse sinus is occluded on one side, the superior sagittal sinus is free, and then all the veins that is draining into the superior sagittal sinus is there. So this is right-sided transverse sinus occlusion. Here you can see that the superior sagittal sinus is occluded, so you have got more of a draining veins, which is collaterals has developed in this case. So these are cases where if you operate and damage these collaterals, then they are going to be in a great trouble. But you can see that the intercerebral vein, the vein of Galen, straight sinus draining into the trochlea, these are normal. So this is a superior sagittal sinus thrombosis. And something about functional MRI, just touching what functional MRI would look like. So here is a left-sided low-grade glioma. So when you are operating on a case like this, then you want to know where the speech area is, where is the Broca's area, where is the Wernicke's area. So you do a MRI called BOLD technique, blood oxygenation level dependent technique, where you can see, you ask the patient to speak, and then you see where the Broca's area is, so that you can avoid that area. Okay. Again, another case of glioma with Broca's area pushed anteriorly, pretty anteriorly. As you know, Broca's area is on the frontal lobe, so it's right at the sylvian area, but then in this case, it has been pushed anteriorly. So you know which place to, if you incorporate this information into navigation system, then you know where to avoid so that you don't damage the Broca's area. Or in another case, you can do awake craniotomy and, you know, stimulate that part and then preserve the speech area. Another case of Broca's area, which is, you know, actually on the surface, very thin surface of the tumor itself in an insular glioma. So these are, so you know, you cannot enter from here, but then you have to enter from here, kind of thing. Wernicke's area, which is in the temporal lobe, which is pushed a little bit inferiorly in this case, again, because of the tumor, low-grade glioma that you can see there. Again, you know, in this case, the Wernicke's area is pushed anteriorly. So you know which place, which area to avoid doing while doing this surgery. And you can also look at the, you know, activate the hand and leg and then find out where the, with the Bolt MRI technique, you can know where the hand area and the leg area is in relation to the low-grade glioma in this case. So it's a superior and posterior. So this is the place where you must avoid to preserve the hand function. Another case of hand area, which is pushed way back, and then so this place is relatively safe. You can go and take the tumor out. So that is the, you know, hand area on sagittal image. And again, the hand area is pushed upward in this case, so you know how to avoid it. Similarly, the foot area, which is in the center, and more in the central area, which is pushed posteriorly in this tumor. So superior posteriorly, again, medial posterior in this tumor. So foot area, you can. So you can also do a diffuse tensor imaging technique, DTI technique, and then, you know, see these fibers in relation to the tumor, like this patient has a pontine glioma, and all the blue, which is the corticospinal tract. Corticospinal tract is going posterior to the tumor. So you know how to avoid while going in. In this case, again, the, you know, DTI, the pontine glioma, the corticospinal tract is shifted posteriorly. I also, while doing surgery, I also put my cursor in each of these axes and see if there is any corticospinal, you know, fibers there or not, and then actually trace out from where I can go in. Similar case. And another possibility with the MRI is MR spectroscopy. Just a few words about, you know, MR spectroscopy is how MRI was actually developed. It was used for testing the chemicals, different chemicals, because different chemicals will have different waveform in a spectroscopic manner. So you look at the chemical within the tumor, and then different voxel will have different chemical waves, and then you can know where which voxel has got which chemical which is high and which chemical which is low, you know. A normal MRI will look like this. The choline is there, Na, the lactate is pretty low. So something like this, you know. I don't want to go into detail on that, but then if there's a you know, like in a high-grade glioma, you see that the choline is peaked, but then you have to match that information with the MRI itself, because, you know, it's a choline is elevated in neoplasm, but also in demyelination, inflammation, and so on and so forth. So everything has to be, you know, combined to give again another choline peak in a tumor. But here is a choline as well as, you know, a lactate peak. So this may be something different. And this is, there's not much of peak in this. So this is actually arachnoid cyst, you know, porencephalic cyst. And metastasis may look like this, although there's a multiple lesion. So you want to differentiate whether this is a infection or a neoplasm, then you can do MRS and find out. So some miscellaneous examples, just, you know, to give you an overall idea. So schizencephaly, where you can see that there's an open type of schizencephaly, the gray matter has gone into the cleft, and then you can see that there's a cleft which is going all the way inside. And this is a neurocystic sarcosis, multiple type. There's two type actually in neurocystic sarcosis. One is an Asian variant where you only see solitary cyst, and in Mexico or in South America you see something like this where there's a lot of, a cyst around the brain on the both side. Cerebellar infarction. So moyamoya disease is another where you can see moya vessels like this with IC occlusion here. On the right side, there's IC is almost occluded, and new vessels have developed to compensate for that, which looks like a puff of a smoke. So moya in Japanese means a puff of a smoke. So moya kind of vessels that you can see. Another moya where you see occlusion of the artery and new vessels generation. And sometimes you can see a lesion like this where there is hemosiderin deposit and a very well clear-cut lesion. So once you see this, then you don't forget this is a cavernoma. I think, this is overall view of what MRI looks like in different pathology. This is arachnoid cyst. The cyst content is exactly the same as CSF. Again, arachnoid cyst where, this and the CSF is almost the same. And here is a Chiari malformation. The tonsil has gone down from the foramen of magnum, and then there's a big syrinx because of the obstruction of the central canal and water hammering into the central canal, leading to the development of syrinx within the spinal cord. So this is the level of syrinx that has gone down. This is a case of a Dandy Walker malformation and almost non-developed cerebellum. A congenital aqueductal stenosis can look like this. And multiple sclerosis is a demyelinating disease where there is a plaques, which is an area of demyelination, which will look like this. And if you have an infective demyelination like long-term infection or HIV, then you can see demyelinating, infective demyelination like this. You also can have metabolic demyelination like in osmotic demyelination syndrome, which is also known as central pontine myelolysis in the past. Now they are using more osmotic demyelination because not only sodium disbalance. If you do a very rapid sodium correction in a hyponatremic patient, then you can have osmotic demyelination syndrome. But you can also see this in uremic patient and also in people who are on a long-term hemodialysis. A very symmetrical type of encephalitis, inflammation of the brain on both sides, maybe due to some involvement of the perforators. This kind of image you see in Japanese encephalitis. Thank you very much, and I will continue with other, how to read normal MRI and abnormal MRI, and maybe angiography, how to read MRI angiography in future. Thank you very much.